first of all, I would like to thank all the organizers, especially Dr. Sumani sir. So it was given to me at the last minute, so not much to prepare, but it's a great trial, I would say. So this trial was done in a very, I would say, a very important subset of the population. So the trial was ipilimumab plus nivolumab and chemoradiotherapy, which is the standard of care, followed by surgery in patients with resectable and borderline resectable lung cancer. It was named as INCREASE study. Please change the slide. Yeah. So of course, next. So the rationale was a segment of stage 3 patients with a high T stage and a low N stage, such as superior sulcus tumors, are typically borderline resectable, and they may become resectable after induction with chemoradiotherapy. So, but it was observed that even after giving chemoradiotherapy, the PCR, the pathological complete response in the specimens that we resected, was very less. So to increase that PCR, it was hypothesized to add immunotherapy, CTLA4 inhibitors and PD-L1 inhibitors. So chemoradiotherapy using a platinum doublet and a concurrent conventional radiotherapy to 60 grays associated with a pathological complete response rates of almost 30%. So chemotherapy combined, don't change please. Chemotherapy combined with immunotherapy in resectable NSCLC improves PCR rates. That has been hypothesized, and that has been proved in some trials also. So it was postulated that preoperative CRT with concurrent dual checkpoint inhibitors, a CTLA4 and a PD-1 inhibitors, could enhance the pathological and immunological response rates through activation of antigen-presenting cells and effector T cells. Next slide. So what was the trial design? The trial design was quite a bit complicated, I would say. So inclusion criteria, of course, a borderline stage 2, B2, 3 CA lung patients eligible for post-induction resection, means they has to be a bit fit patients rather than very old and frail, PS 0 to 1, and there was and the N was calculated based on some, it was calculated as 26 to 29. So there were 26 evaluable patients in them. Very small number, but yes, it was statistically okay. So what they did, they gave the chemoradiotherapy as the standard thing, plus they added the ipi-nivo, 1 dose at the starting of the chemoradiotherapy, and also 1 dose of nivolumab after day 21 days of chemoradiotherapy. So of course the staging was done as it is done for all our patients, with a PET scan, with the MRI brain, and of course the mediastinoscopy if it is needed for complete staging of the patient. And within 6 weeks of completion of the chemoradiotherapy, patient was resected. Patient underwent resection, and then the PCR was measured, of course, in the resection, and PCR was, of course, a complete absence of tumor, and there was also measured major pathological response, in which less than 10% of the specimen showed the tumor. And then, of course, there was follow-up. The primary endpoint was PCR, secondary were DFS and the OS. Next slide. It was a phase 2 trial. So if we see this, so we have a median age of course, the elderly, 64 was the median age, almost similar male and female. Smokers were more, and then they were all PD-L1 expression was it was mixed PD-L1 expression, and this is the data. Okay, next. So yes. So this talks about the adverse effects in these patients, because in chemoradiotherapy also we observe much adverse effects in these subset of population. But with addition of immunotherapy, yes, we have the adverse effects bit increases, not much, and it was quite manageable. So any adverse effects was almost every person had the adverse effect. But yes, the grade 5 was 0 among this, and any patient leading to IU discontinuation was only 7% in 7% of the patient. So the most common adverse effects for dermatitis, and then there were thyroid disorders, pneumonitis that we already know with the immunotherapy. Next slide. So PCR. So we can see the patient who underwent resection, The PCR was present in 63% of the cases. Yes, it was, the number was small. It was 15 patients out of 24 patients. But yes, still it was 63% of the patients who achieved PCR, which is a big deal because chemoradiotherapy has the data of only 30%. That is almost doubling of the PCR. MPR, if we would say, that is major pathological response, which was also present in a 79% of the patients. So we can see the tumor regression was almost very high, as in this plot we can see almost 100% was many patients, and very few patients had very less response. So of course these patients, this subset maybe having different biology. Of course that has to be more done and more investigated in further trials, but yes, the response rates were quite awesome. Next slide. So what you would say, the PCR was good, but the radiological response was not very good. So if we would see, the stable disease was present in 81% of the patient, if we can see in this thing, and they were resected also. But for the patients who had stable disease, they had PCR in 87% of the patients. So radiological response is not the ideal thing to actually judge how patient has responded. That inference can be made from this. So next slide, please. So this is just a case that they have told, that there was a 43-year-old man. Don't change the slide, please. Please put on the slide. Yes. So we can say there was a radiological stable disease was there, but metabolically the patient had a complete response, and of course the pathological patient had a PCR. So of course CT, we all know PET CT is a better modality, and we should always assess with a PET CT. And we should notice that in this, the PET CT was done within a month of the CRT. It was not done after 3 months, but within the 1 month of the CRT, and then they did the resection after 6 weeks. Next slide, please. So the hypothesis is that when we give the immunotherapy before the resection, it induces memory T cells. It increases the CD8 plus T cells, which actually decreases the recurrence of the disease. There is memory T cells which eats up, of course, the cancer cells, and the body is more primed to kill cancer cells rather than only with chemoradiotherapy. So that's why immunotherapy has to be given in neoadjuvant setting rather than adjuvant setting, in which there is more antigen load, more T cells would be activated, and then they will become the memory T cells, and then thus they would lead to decrease of recurrence of the disease. So you can see in the last so activated CD8 increase versus control was there. So we can see there was a quite increase in the CD8 plus cells. Whether it translates into DFS or not, that is of course still a debate to be investigated. Thus yes, this is the hypothesis that is being given for usage of immunotherapy in a neoadjuvant setting. Next slide. So we can conclude this is the phase 2 trial still. In a selected population comprising borderline operable high T and low end stage tumors, Ipi-Nivo, single dose Ipi-Nivo plus 1 Nivo with concurrent chemoradiotherapy resulted in high pathological response rates of almost 63% PCR and MPR of 79% in the operated patients. Toxicity rates were almost similar, were acceptable, and no patient failed to undergo surgery due to adverse effects. The regimen of the chemo-radioimmunotherapy may be associated with increased CD8 plus T cell proliferation in the tumor draining lymph nodes and in blood, and may result, we don't know yet, but still may result in a greater DFS that we can have. Thank you so much.
Thank you, Dr. Aditi, for your nice presentation. And we sincerely hope that the hypothesis we have proposed may come true and more people get benefited from that. So next speaker is Dr.